Bonsoir, bonsoir et bienvenue à toutes et à tous. Good evening, Excellencies, distinguished guests, ladies and gentlemen, friends joining us here in Geneva and online from around the world. Welcome to this high-level dialogue on aligning the global health architecture for equitable access to health commodities. I'm Folie Batibo, and it is my great pleasure to guide you through this important conversation on the sidelines of the 79th World Health Assembly. Our sincere gratitude to the permanent mission of France to the United Nations in Geneva for hosting us once again this year and for its continued leadership in advancing global health dialogue. And to Medicine's Patent Pool for making this important gathering possible yet again by bringing together actors across sectors and region around one central question: how do we make access more equitable, faster, and more sustainable? We'd also like to warmly acknowledge our partners, the World Health Organization, for their continued engagement and commitment to shaping a more equitable and resilient global health system. Now, this is the fifth high-level dialogue convened in this format, and each year the conversation has evolved, reflecting both the progress, the lessons learned, and the new realities confronting global health. Now, tonight's discussion comes at a particularly important moment. Recent concerns around the hantavirus outbreak, the Ebola epidemic in DRC, are once again reminding the world that pandemic threats do not disappear because fatigue sets in. Preparedness cannot begin only when headlines return. Preparedness is also about ensuring that when innovation happens, whether it's vaccines, diagnostics, therapeutics, people everywhere can access them rapidly, affordably, and equitably. And that is precisely why we're having this conversation this evening. So we've got an exceptional lineup of panelists for you over the next hour and a half. Very much looking forward to hearing their insights and their experiences in their respective fields and their respective countries. We're honored to have among us the Minister of Health from Senegal and hopefully soon the Minister of Health from Tunisia as well. But to begin, it's my honor to invite France's Ambassador for Global Health, Anne-Claire Amprou, to deliver opening remarks.
Mesdames et Messieurs les ministres, Monsieur le directeur exécutif d'United, Madame la directrice générale de CEPI, j'ai aperçu Charles Gore aussi quelque part, mais il a disparu. J'ai la lourde charge d'accueillir tout le monde ce soir dans un contexte où, au Palais, nous avons pris beaucoup de retard. Et parallèlement, la ministre Stéphanie Ries a dû partir plus tôt pour gérer une urgence à Paris. Et donc, je vous accueille chaleureusement ce soir ici à la représentation permanente de la France pour, comme vous l'avez dit, la 5e édition de l'événement organisé ici avec le Medicine Patent Pool. Et nous en sommes très heureux. Pour cette édition 2026, nous avons décidé de dédier ce dialogue à la réforme de l'architecture en santé mondiale sous un prisme particulier qui est le prisme de l'accès équitable aux produits de santé. Il s'agit d'un enjeu majeur, vous le savez, et merci d'être là ce soir nombreux pour pouvoir en discuter. La réforme de l'architecture en santé mondiale est un axe transversal et important dans la stratégie française de santé mondiale. Et dans le cadre de la présidence française du G7, nous nous sommes saisis du sujet et de cet enjeu, notamment en organisant début avril le One Health Summit à Lyon. Nombreux d'entre vous étaient à Lyon. Nous avons organisé une réunion de haut niveau consacrée à la réforme de l'architecture en santé mondiale. Et cette réunion était présidée par le président de la République française, en présence de plusieurs chefs d'État, qui visait à rassembler l'ensemble des parties prenantes intervenant dans les réflexions sur la réforme, c'est-à-dire les États, les organisations internationales, les organisations régionales, les banques de développement, la société civile et les philanthropies. Et cet événement a permis de donner une nouvelle impulsion aux réflexions en cours et de faire dialoguer des initiatives relatives à la réforme de l'architecture. Alors, comme vous le savez, il y a beaucoup d'initiatives, beaucoup d'enceintes de réflexion engagées sur ce sujet, et ce qui est très bien. l'objectif aujourd'hui, c'est de rassembler l'ensemble des acteurs, les acteurs du Nord, les acteurs du Sud, les publics et privés, pour mettre en cohérence et aboutir à des recommandations qui soient concrètes et opérationnelles. C'est ce dont nous avons besoin. Et cette réunion à Lyon a donné lieu à l'adoption de la déclaration de Lyon qui, justement, entérine les points de convergence et consacre le soutien des acteurs de l'écosystème au processus de réflexion conjoint et inclusif sur la réforme de l'architecture qui est actuellement en cours à l'OMS et qui est à l'ordre du jour de cette Assemblée mondiale de la santé, je crois, plus tard au cours de la semaine. Ce processus de restructuration de notre écosystème doit avoir pour boussole certaines valeurs cardinales, et en particulier celle de l'accès équitable aux produits de santé qui guide notre action et qui est l'objet de la réflexion et des réflexions que nous allons avoir ce soir. Et à ce titre, évidemment, organiser cet événement avec le MPP était pour nous important. MPP créé il y a plus de 15 ans, qui à l'époque incarnait une audace dont nous sommes capables dans ce domaine et qui est toujours d'actualité avec le MPP qui est progressivement devenu un outil qui remplit cette fonction essentielle dans l'écosystème en santé mondiale pour élargir l'accès aux traitements à moindre coût et dans les pays où nous en avons le plus besoin. Mais l'accès aux produits de santé ne sera véritablement équitable que lorsque les sites de production seront eux-mêmes géographiquement diversifiés avec une production plus proche des besoins. Tout l'enjeu de ce qu'on appelle la production locale et la production régionale. Et c'est une thématique, une priorité que nous avons aussi mis à l'honneur au sommet Africa Forward à Nairobi, plus tôt cette semaine, il y a juste quelques jours, avec une table ronde dédiée à ce sujet au nom de la souveraineté sanitaire sur le continent africain, en se focalisant sur le sujet de la production locale et régionale. Et là aussi, nous avions un large panel avec l'ensemble des acteurs et surtout des annonces de livrables à fort impact. C'était ça l'enjeu et c'était ça l'objectif, avec par exemple le lancement du programme M2030 de la Banque mondiale, le financement par l'Agence française de développement et la Banque européenne d'investissement du projet Biovac pour le développement d'une chaîne de production multivaccins en Afrique du Sud, ou encore l'annonce majeure faite par United, mais je suis sûre que Philippe Dunton y reviendra, d'un accord avec l'Afrique du Sud pour la production de bout en bout de l'Enacapavir. Et l'objectif, encore une fois, était d'avoir des annonces concrètes et de faire avancer l'agenda de souveraineté sanitaire et du continent africain. Pour s'inscrire dans cette continuité des annonces, il nous paraissait essentiel que la nouvelle architecture en santé mondiale endosse cette approche partenariale qui a été mise en évidence, que ce soit à Lyon, à Nairobi ou ici à Genève, pour créer des passerelles entre l'innovation et l'accès, et notamment articuler les efforts entre les différents acteurs. Donc nous allons ouvrir ce segment avec le MPP sur ces sujets-là. Je me permets évidemment d'insister sur l'engagement de la France sur ces sujets-là, qui reste évidemment toujours mobilisé aux côtés de l'OMS, du MPP, d'United et l'ensemble des acteurs, et merci d'être là, pour faire de cette ambition une réalité. On le doit à nos partenaires, on le doit à nos populations, y compris pour un enjeu de souveraineté sanitaire, mais aussi de sécurité sanitaire. Et donc, je vous souhaite un bel événement ici à la représentation permanente de la France à Genève.
Merci beaucoup, Madame l'ambassadrice, pour vos propos et pour l'engagement constant de la France en faveur de la coopération mondiale en santé. Merci. We now turn to a special video message from the Director General of the World Health Organization, Dr. Tedros Adhanom Ghebreyesus.
Honorable Ministers, dear colleagues and friends, I thank France and the Medicines Patent Pool for convening this discussion. The COVID-19 pandemic exposed wide inequities in access to essential health products. Despite progress in research, manufacturing, and supply, if the next pandemic were to arrive today, we would face the same inequities. No single instrument, whether research, licensing, manufacturing, financing, procurement, or country implementation, can deliver equitable access alone. We need a more coordinated and aligned ecosystem. As member states and partners consider reform of the global health architecture and the implementation of the pandemic agreement, equity must be built into every step from innovation to delivery. More sustainable and geographically diversified manufacturing is central to this effort. The mRNA Technology Transfer Program, co-led by WHO and the Medicines Patent Pool, shows what is possible when we work together, strengthening country ownership and regional manufacturing capacity. Phase 1 has demonstrated the concept. Phase 2 is now essential to secure sustainability, readiness, and long-term impact. This is one example among many. Licensing, patent pooling, regional platforms, technical assistance, and the WHO Health Technology Access Program are all helping to connect innovation, production, and delivery. We must move from principles to action with the political and financial support needed to deliver for all. Thank you all for your commitment to ensuring life-saving health products reach everyone, everywhere. Merci beaucoup. I thank you.
Thanks to Dr. Tedros for setting the global perspective and reminding us both of the urgency and the opportunity before us. Now, let me take a moment to frame our discussion this evening. We meet, as we've heard, at a pivotal moment for global health. Here at the World Health Assembly, member states are engaged in shaping the future of the global health architecture through discussions on the pandemic preparedness and the PABS annex, and also broader reflection on how to strengthen preparedness, response, and health security. At the same time, we are confronted with a stark reality and a persistent reality as well. Nearly 2 billion people around the world still lack access to the medicines they need. Now, this is not due to a lack of innovation. In fact, in recent years, we've seen remarkable scientific progress at an unprecedented speed and scale. But innovation alone doesn't guarantee success or access. The real challenge lies in how innovation moves or fails to move across the system. From R&D to licensing to manufacturing to financing, procurement, and ultimately delivery at the country level, each step must be connected. And too often, those connections are weak, fragmented, or misaligned. The result is a system that delivers breakthroughs, but not always equitably. And in today's context, where global health financing is increasingly constrained, the need for smarter alignment is more urgent than ever. What matters today is how all these pieces come together. So this evening, what we're going to do is explore where the alignment is working, where it's falling short, and crucially, what practical, cost-effective solutions already exist that we can scale. So we've got two exceptional panels lined up for you to guide us through the first part of the conversation. Please welcome to the stage Aurélien Nguyen, Deputy CEO of CEPI. Join us. His Excellency Ibrahim Sy, Minister of Health of Senegal. Please join us. Also with us, Catherine Lofthus, Director General for Health of the Norwegian Directorate for Health. Join us on stage, please. Yes. Go ahead. We're very pleased to have with us as well Blanca Yanez, Deputy Director for Multilateral and EU for Spain. Thank you so much. And And I will ask also to join us for this first panel, Florica Fink-Hoyer. Please join us on stage, Director General of HERA. Thank you for joining us. And we are waiting, hopefully, joining us in a few minutes from the CDC, a representative from the Center for Disease Control, the Africa CDC, hopefully in just a few minutes. But I'll begin with all of you who are here. Thank you so much for your time. I mean, at a time of constrained financing and ongoing reform, the central question today is how do we ensure innovation translates into equitable access effectively and consistently? Aurelia, let me start with you and get the perspective on innovation and early stage alignment. We've seen remarkable progress in innovation in recent years, and yet translating that into equitable access remains a challenge. So from your perspective, where are the key bottlenecks, the key challenges, and how do we address them more effectively?
Thank you for the question, and I will speak English in a minute, mais tout d'abord, je voulais prendre l'occasion de remercier la représentation permanente de la France aux Nations Unies et aux organisations internationales, Madame l'ambassadrice, de votre accueil, ainsi que Medicine's Patent Pool. So switching back to English, thinking about the barriers to access, I was reflecting along my career how access barriers have evolved. And I started off my career in the pharmaceutical industry in the 90s. And at the time, the products were not right because all of the vaccines were being made in pre-filled syringes, or for pneumococcal vaccine, the strains that were affecting countries with the highest burden of pneumococcal diseases were not being included in the vaccines. And so there was quite a lot of work, and I think the industry has actually come quite a long way along this journey, thinking about this adaptation. And then afterwards, when I moved to Gavi, one of the things, particularly in the early days of Gavi, that I found quite frustrating was that by the time products were available for use, they were also with huge access challenges. And for example, on hexavalent vaccine, we had to wait for the price to be able to come down. We had vaccines that needed a lot of ultra cold chain, and so those made them very, very hard to deliver. And so essentially now that I'm with CEPI, and I think this question around access really underlines how much it's an end-to-end issue that we need to address, and that starts right at the beginning when we think about research and development. And that's a lot of the work that CEPI is doing, to think about how do we look at access barriers in their manifestations. And so that is thermostability, it's the cost of goods, it's what schedule, how many doses do you need, how do you think about which family of viruses you're working on. So all of these things need to be thought of right from the very beginning, because the access issues flow all the way down, and you can't think about it at the point that you're going to want to deliver. And then the second thought was also around how access needs to be thought about through a systems approach. And so there are very, very practical things that we can do. From CEPI's perspective, we fund manufacturers. We're able to negotiate the access through the contracts, so in exchange for de-risking the development. One example would be with Moderna for their phase 3 trial of H5N1, being able to negotiate in return 20% volume in the case of a pandemic for lower income countries. So those are very, very concrete measures, as well as obviously the indirect work that can be done. So it's about the R&D part, it's about the systems. And then lastly, I would say the access barrier to think about is around getting our ecosystem to be integrated and networked. And so it's actually very, very fitting that one of the very good partnerships we have between CEPI is actually with the Medicine's Patent Pool. Mm-hmm. We have an MOU, it spans R&D, manufacturing, IP, licensing, preparedness. And what I really like about it is that the principles that we've enshrined in the MOU are about equitable access, transparency, IP, and non-duplication, so that we're really thinking about who does what in the system and how we focus that to access to access barriers. So those, I think for me, are some of the key barriers that we are making a lot of progress on, but we really still have some improvements, and we can push further on this. Thank you.
Thank you very much, Aurelia, for your insights, and thank you for highlighting some of the progress that's been made there, despite the bottlenecks and challenges that remain. I'll come next to the Minister of Health for Senegal. Merci beaucoup, Monsieur le Ministre, d'être parmi nous aujourd'hui. Et je vais poser la question en anglais, mais bien évidemment, vous allez parler en français. Mais je vais la traduire si vous le voulez bien. Parlez-nous de l'expérience du Sénégal et comment vous pensez les pays pourraient mieux intégrer l'innovation dans leur système de santé national.
Merci beaucoup. Permettez-moi tout d'abord de remercier la représentation permanente de la France pour avoir convié le Sénégal à cet événement. Vous savez, au Sénégal, nous avons élaboré un nouveau référentiel des politiques publiques à travers l'agenda national de transformation Sénégal 2050, dans lequel nous avons un axe majeur qui porte sur le développement d'un capital humain de qualité, où il y a une priorité importante axée sur la relance de la production locale de médicaments, de produits de santé, mais aussi de vaccins. Mais pour ce faire, on a essayé de voir l'approche, parce que la vocation du ministère de la Santé, ce n'est pas de manière primaire de développer l'industrie. Mais on s'est dit que même si on a besoin de produire des médicaments, des vaccins, il faut que le ministère de la Santé travaille avec le ministère de l'Industrie pour que le ministère de l'Industrie porte le projet sénégalais d'industrialisation pharmaceutique, en essayant de garder à l'esprit au moins ces trois volets, les médicaments et les produits de santé, avec une approche très bien déterminée. Et l'approche, c'est de voir un peu comment faciliter l'accès au financement, comment faciliter l'accès au foncier, comment réduire la fiscalité et comment ouvrir le marché aux potentiels produits qui sont mis sur le marché. Et pour ce faire, le Sénégal compte sur ce qu'on appelle les innovations technologiques, surtout le transfert de technologies. Parce qu'aujourd'hui, si on n'a pas la capacité de pouvoir produire, il y a une nécessité de faire les joint ventures. Ces joint ventures peuvent se faire au niveau africain, mais ça peut se faire aussi avec des firmes au niveau international qui vont accompagner les entreprises sénégalaises qui veulent se lancer dans la production locale de médicaments et autres produits de santé, à le faire progressivement en essayant de voir comment ouvrir aussi le capital à ces entreprises-là. Maintenant, surtout en termes de peut-être innovation achevée, c'est le fait d'avoir le projet Madiba au niveau du Sénégal pour produire les vaccins. Et ce projet va permettre aujourd'hui une autonomisation du Sénégal, mais de beaucoup de pays de la sous-région, surtout pour ce qu'on appelle la vaccination de routine, mais également de pouvoir se préparer par rapport à la riposte aux pandémies en développant tous ces vaccins liés qu'on appelle ARN messager, qui aujourd'hui, une fois que la technologie est disponible, on peut produire des vaccins, on peut l'adapter à tout type d'épidémie qui risque d'apparaître. Maintenant, cela demande quand même des investissements extrêmement importants, et c'est pourquoi on est en train de faire ce que l'on appelle les partenariats publics-privés, c'est de voir comment attirer des investisseurs qui soient nationaux, qui soient régionaux, ça veut dire africains ou étrangers, à venir soutenir cette vision de production de vaccins au niveau du Sénégal. Maintenant, il faut que tout cela puisse se faire dans le cadre d'une coopération, mais d'une meilleure coordination au niveau sous-régional, en essayant de mettre aussi en avant l'agence africaine du médicament, mais en essayant aussi de renforcer les capacités des réglementations africaines. Ça veut dire, par exemple, au Sénégal, nous, on a l'Agence nationale de réglementation qui a eu à atteindre le niveau de maturité 3, qui dit aujourd'hui que le pays peut fabriquer des médicaments qui seront de très bonne qualité, qui seront sécures et qu'on peut facilement vendre aussi au niveau étranger. Voici à ce niveau les points que je voudrais peut-être mettre en avant en attendant de pouvoir évoluer dans le débat. Merci beaucoup.
Merci beaucoup, Monsieur le ministre, d'avoir souligné l'importance non seulement de la coopération interne entre les différents ministères au Sénégal, mais aussi de la coopération régionale et la coopération sud-sud qui est très importante. Merci beaucoup. Thanks to the Minister of Senegal, Ibrahima Sy. I would like to ask the representative from Africa CDC who's joined us to join us on stage, Mosaka Papa Fala, Africa CDC. This is a busy time for you all, I know, especially with the recent outbreak of Ebola in the DRC and Uganda. So thank you for taking the time to be here with us today. Thank you so much. I'll give you a few minutes and then I'll come to you in a few seconds with a question. But Florica Fink-Hoyer, if I can come to you next and get the perspective of policy and system mechanisms. We've seen, as we've heard, important progress in strengthening preparedness mechanisms since the COVID-19 pandemic. But where do you still see the gaps in ensuring that these translate into equitable access in practice?
Thank you very much for the question and good afternoon. First of all, I think we all would agree that equity and equity and access will not be ensured when you just go on deployment. That's too late. And everybody has already before me spoken about the end-to-end approach. But even in the end-to-end approach, you fear gaps. And ensuring an end-to-end approach is quite costly. One should not forget that. I think it also requires national ownership and a bit of national spending. I'm saying that because I know that as European Commission, but also with the Team Europe approach, and La France is one of the strongest defenders for that, we have always pushed for local capacity building, local manufacturing. But that alone is not enough, and I've seen Mediva and others, and I'm full of praise for that. But it needs more, and in the Global Health Resilience Initiative, which we just adopted, we put out a few other elements. Local capacity building is one. But you also have to look at, when you look at countermeasures, ensure no gaps. It has to be therapeutics, it has to be diagnostics, it has to be vaccines. And all of this has to be coming together. Again, this is not easy and it is costly. But it is what we have to try. Otherwise, again, we face gaps and we cannot ensure equity. So that's not good. Let's look at the demand side. Demand side means you have to give a certain reassurance to the manufacturer that there is an uptake. Otherwise, they would not engage. So that can be with advanced purchasing agreements, that can be with joint procurement. But again, this has to be thought through, and that has to be ensured with more partners and not just one. And we have joint procurement, for instance, for 38 participants in the European Union when we work as HERA, and that allows those who would have normally the least access to have a seat at the table and therefore get access. So that's, I think, is quite important. We have experience with a few things how to scale up. One is ever-warm capacity or ever-warm manufacturing networks. We call it EUFAP. We try to now also expand that elsewhere. But again, this is quite costly. But it's the only way to ensure that there is scalability at the moment when you really need it. You cannot leave a manufacturing pipeline without having something produced because the workforce is gone, the know-how is gone, so you need to keep that also warm, and that's quite important. Another element I would like to point out is We expand manufacturing base also through technology sharing, and the tech sharing is not easy either. And here we work together with WHO, but also with implemented with the Medicines Patent Pool, with what we call the Health Technology Access Pool, and that is the HTAP. It's voluntary, but it's important in order to make sure that there is this transfer of not only the technology, but also the know-how, and also keep a pipeline ongoing, because as I said, it doesn't make sense if you have the best facilities, but you're not using it constantly. So that is something which is very important. Joint procurement can help, as I said, but then let's look at supply chains. We are constantly looking at supply chains, because that's where the blind spot for our politicians lies. They think it's all accessible at that moment, but it's, as the minister has said, there might be trade observations, there might be diplomacy observations which stand in the way. Right. So that we have to really make sure that we look at where are the APIs, where are not only the APIs but also the key starting materials, and are they available? And obviously none of us is able to ensure a full pipeline. So we need collaboration. We tested that now with a study that we launched together with OECD. This is not earth-rocking in what the findings were, but it definitely shows that on supply chains we all have gaps and all fragility, so we really need to work together on that, and that's extremely important. A last one which I wanted to mention also, which is helping us to ensure more equity, is the work that we do with WHO on the IMCM-net. I think by launching a series of workshops on how to do pooled procurement. We do this with regional actors. We are one regional actor, POW is another actor, a regional actor, African CDC is another actor. We all have different experiences, know-how, and we can learn from each other, especially as also in Asia, there are other ones who would consider now going on to pooled procurement or want to start this up. So this is where we have launched now a series of workshops. We did this first in Brussels. We hope to do this in Malaysia now at the next time, and then continue like this. Because the whole logic is our architecture is fragile. And collaboration, know-how, transfers, all of this are bits and pieces of the puzzle to ensure equitable access. Even if one partner thinks it's very strong, is never strong. We always need each other, and that's probably the lessons learned. And I very much agree with really what you said. Is I saw it also in Madiba. They were very smart on looking at already the bulk production and not just with the syringes and others. So there's so much progress that we have learned from each other, but we can't do it alone. Thank you.
Collaboration is key, isn't it? Thank you very much, Florica, for that. Well, you talked about the regional experience, so I think it's important that we get the regional perspective. Mosaka Papafal from the Africa CDC, from a regional perspective, what's made the biggest difference in improving access to countries, and what do you think needs to change to improve the impact going forward?
Thank you very much. I don't know if we can speak about access. The reason I'm here now is because Chanel is on the way to DRC.
Yes.
To respond to the Ebola Budumbuyo. And I've been involved in responding to Ebola for the last 12 years of my career. The next thing is that you can see from my face, I haven't slept for probably 3 days. And it reminds me so much what we saw happening in 2014 in West Africa. And we predicted this at the end of 2014, that we had 3 strains of Ebola that would one day become an epidemic or pandemics. We knew that Sudan would come up, and we knew that Budumbuyo would come out, and we proposed the lesson from Ebola Zaire. But in 2022, when Ebola Sudan started in Uganda, there was no medical countermeasure. There was no manufacture. Then in 2025, I was in Africa CDC, were in Tanzania. I had to fly all night to fly in for the Ebola Sudan. we had a similar situation. We had countermeasures that were still in experimental stage and couldn't get in time to the people, and the outbreak, and then now check a year later, we're dealing with an expanding outbreak in the DRC, in Uganda, with a very high risk of spillover to South Sudan. The intersection, but all of the time, what we've seen is that we're still in this panic mood. We've never been able to manufacture medical countermeasures when all of the variables and factors were telling us will come to this day. I was talking to a close friend of mine who said, Mosoka, it seems as though we're going to go back to 2018 Ebola Zaire in the DRC. The rate at which it has spread.
So why do you think we weren't better prepared?
We've never been able to prioritize. The market forces has always decided what medical countermeasure is produced. That's the biggest thing, issue of medical countermeasures, stockpile. It's the market forces that is driving that. But what key lesson we've learned is that there's always a potential threat that the isolated area becomes the center for global spread. So that's one. We agree that there is some very critical point, the issue of funding domestic financing of R&D. You know, the sad thing was that as we're in the meeting this morning, and there is a potential vaccine developed by the University of Texas Medical Branch, but it's at the laboratory stage. We are now trying to accelerate that to a GMP grade. But what was sad as we're looking across the continent, we cannot find a single manufacturing company on the continent that can be able to produce this GMP grade as fast as we will need it to deploy it for the response. After all of the years of investment, we don't have a single company now, manufacturer, that can be able to move. So we have to go outside of Africa to manufacture. So we have to shift from talking to action and investing. I think there are two critical issues I want to touch. One, as she's correctly said, domestic financing for R&D is critical. We cannot always depend on donor support. Tomorrow, I will encourage many of us here to come to a section we have with Team Europe. We've commissioned a study to look at the return on investment if Africans invest in R&D. What we found is that in 20 years, we can have $668 billion on the continent. We can be able to create about 5 million jobs. We're using that as a tool to convince our politicians and African businesses that R&D has a return. You know, it has a transformative power for economic transformation. But the second thing we're saying is that it supports medical countermeasure. The third thing is our mindset, the framework we use for manufacturing. I understand perfectly, outbreaks will not always happen. How do we create agile and flexible manufacturing plan that deals with the endemic diseases, but is flexible to respond for medical countermeasure? It's that tension we have to resolve across that full stream. That's critical for us to decide, but the lessons are very adequate. There's going to be a new outbreak. There's going to be a new outbreak. We're facing one in the last 3 years. I've probably been in almost 12 countries responding to outbreaks that we knew would happen. Thank you.
Thank you so much. Thank you for that, for sharing that experience with us and the lessons learned and not learned from that previous outbreak. Thank you very much, Mr. Falla, for that. Let me come to you next, Catherine Lofthus from Norway. Florica talked about the need for more partners, more partnerships. How can multilateral partners, do you think, better complement each other? It's good to have more partners, but how do they complement each other to get better access?
Is this on?
Yes.
Yeah, thank you. And thank you to the French mission and the Medical Patent Pool to host this high-level conversation on a really important topic. And to succeed in achieving equitable access, these considerations need to be embedded throughout the development and life cycle of health products. This requires collaboration and coordination across the value chain. We really need to align our access objectives from partners involved in upstream product development to partners further downstream focused on delivery. And for pandemic emergencies, the pandemic agreement stakes out a course for this already, pointing to the establishment of the global supply chain and logistic network. And I would also like to draw your attention to Article 9.5 of the Pandemic Agreement that Norway proposed and secured in collaboration with Mexico, highlighting the importance of attaching condition for equitable access into public financing of research and development. Also here we need collaboration between funders to align on common policies and objectives. So we look forward to working with other partners to take this work forward. And we need strong political leadership, and that's essential to build consensus on shared objectives and translate them into concrete measures. Because we face economical constraints, so then we need coordinated and aligned systems. And we've heard some examples today from the WHO in collaboration with the Medical Patent Pool and also from CEPI. And I think we will hear from Gavi as well, so we have something to build on. And for Norway, it is of great importance to reach a joint process to reform the global health architecture. And the goal is a strong global health ecosystem supporting national priorities with more efficient use of health resources. And more equitable access to health products is a really important part to reach universal health coverage. Thank you.
Thank you very much. Thanks for that and for sharing your perspective with us. Blanca Yanez, I'll come to you with the same question from a funder's perspective. How can multilateral partners better complement each other to advance equitable access?
Well, first of all, I would like to thank the French permanent representation as well as MPP for the organization of this event and for counting with Spain. From our perspective, we consider first that, and I would address first what we as a country will need to do, which from a perspective, which is a development agency, we need to keep on investing. It was just mentioned how all the countries will need to invest, and we need to reinforce our commitment with global health and increase the funds that we assign to this matter when it's possible. Second, we, as it has been mentioned by other members of the panel, we need to work together globally, regionally, and nationally. And from the Spanish perspective, multilateralism is a very important angle. As we, for example, we just saw it in the last weeks with the hantavirus crisis, that the multilateralism and the WHO gave us the frame in order to how to address an international crisis. Also, we need to embed equity, as it has been mentioned by other members of the panel, from the very beginning, as it was already said at the very beginning, because innovation should be a trigger for equity and access, and if we don't consider it from the very beginning, it is very difficult to include it after. And finally, I would like also to express the importance of advancing and find compromises to reach an agreement on the PAPs and to advance in the implementation on the pandemic agreement. And we from Spain, we are ready to do our part. Thank you.
Thank you so much. Thank you for Spain's engagement and commitment. Perhaps, I'm sorry, perhaps we can just hear a final word from the Minister, who I think wanted to add one additional comment before we bring in our next panel. Peut-être un dernier mot, Monsieur le Ministre.
Merci beaucoup. Le dernier mot, c'est juste l'inspiration que m'a donné mon collègue d'Africa CDC, qui aujourd'hui travaille dans un contexte extrêmement difficile. Il faut que la gouvernance mondiale intègre les conflits et les guerres. Parce que quand on a les conflits et les guerres, on est dans une rupture d'égalité. Ça veut dire qu'on ne peut plus assurer un accès équitable à des médicaments et autres produits de santé. Et c'est ce qu'on est en train aussi de vivre à travers le détroit d'osmose, où beaucoup de produits de santé commandés n'arrivent pas à temps et à bon port au niveau de certain nombre de pays. Et aujourd'hui, ça hypothèque toute la stratégie de santé publique qui sont bâties dans un certain nombre de pays. Donc, il faut que la gouvernance mondiale pense à ces risques et voit les moyens de pouvoir les mitiguer et de pouvoir les anticiper. Merci.
Merci beaucoup, Monsieur le ministre, pour vos propos. C'est très important, en effet, de comprendre et d'introduire le contexte quand on parle d'accès. Thank you all, to all of our panelists. Please, another round of applause for our panelists joining us on stage. You may return to your seats. Thank you all very much for that rich discussion, from innovation and licensing to delivery and implementation. What emerged from that conversation is that equitable access doesn't depend on a single breakthrough. It depends on systems that are coordinated before a crisis hits. And that brings us directly to our second conversation now, in the context of the ongoing World Health Assembly discussions on health security and sustainable preparedness. We now ask what mechanisms are already working to deliver equitable access, and what can they teach us about smarter, more cost-effective preparedness for the future. So I'm pleased to introduce our second panel to the stage. Joining us is Dr. Sania Nishtar, CEO of Gavi. Thank you very much. Dr. Marie-Paul Keeney, Chair of the Board of Medicine's Patent Pool. Also with us, Thomas Scheeneke, CEO of Roche. Dr. Philippe Dunton, Executive Director of Unitaid. Agre Aluso, Resilience Action Network Africa, is also with us. Please join us on stage. Peter Sands, Executive Director of the Global Fund. He's arriving. Okay. He's going to join us in a few minutes, hopefully. Thank you so much to all of you for being here. And we're expecting one or two more, but hopefully they'll be with us very soon. Thank you for your time this evening. I know it's a very busy time during World Health Assembly Week. Dr. Sania Nishtar of Gavi, if I can start with you. We've talked about solutions that already exist, but scaling them remains a challenge. So from your experience, what enables access to happen at scale, and what still holds it back?
Well, good evening to all of you, and as always, a pleasure to be here at the French mission. And thank you, France, for your support to global health more broadly. I think your question is a very important question, because if you have solutions and if you can't deploy them at scale, you don't reap the benefit. So in order for solutions to be deployed at scale, you need to have the right business model. You need to have tight governance arrangements in place. You need to be able to leverage on the comparative advantage of partners, both within the public and private worlds. You need to be very clear on the outcomes, on the metrics, and you need to focus on measurable results and accountability. And I think all these ingredients are very, very critical. Partnerships are very important to delivering on scale, because the public sector has certain competencies, the private sector has others, the UN entities have other capabilities, and it's only when you join the dots appropriately that you're able to deliver at scale. I'll give you the example of Gavi. What was the problem we were addressing? So back in the late 80s and the early 90s, vaccination, the R&D in vaccination was progressing. As Mary Paul will tell you, she knows the history well, solutions were becoming available, but the utilization of vaccines had stalled. It had peaked. Because countries were finding vaccines unaffordable. Price was a real barrier to access. And that is where Gavi, the Vaccine Alliance, was established to ease that barrier. And Gavi had a specific business model in which it crowdsourced demand from representing 6 out of 10 children anywhere, born anywhere in the world. That's a very huge ecosystem. And then making that demand for vaccines available to the manufacturers over a long period of time, based on which Gavi was able to drastically negotiate the prices of vaccines downwards. To give you an example, in a Western developed nation, it might cost about $1,000 to give a child a basic course of vaccines. In a Gavi-supported country, it costs less than $30. That was because of the design of the business model. Crowdsourcing demand, pooling demand, making that demand available over a long period of time to manufacturers, and negotiating prices, special packages, special delivery arrangements. That's the one thing the model was able to do. And then the model was able to leverage the comparative advantage of partners on the ground rather than opening 200 offices in every country. And that model has really enabled us to vaccinate 1.2 billion children over the last 24 years, saving 20 million lives. And for every dollar accrued, every dollar invested in Gavi, you accrue $54 in economic benefits. We work at a 3% operational cost, very lean organization, and our sister agency, the Global Fund, has a similar story of scale and agility and delivery at very low cost. So I think you need to get the right business model in place. You need to leverage the comparative advantage of all the actors and be very simple in what you want to achieve and be very clear on the metrics and outcomes. And that is how you're able to achieve scale. For instance, we are focusing on achieving scale now at a very different dimension, because there are two legs of Gavi. The one leg starts from the manufacturing facility, ends at the tarmac of countries where we deliver the vaccines. And in that leg of Gavi, we do extremely well. But then the subsequent leg of Gavi is from the tarmac to the arm of the child, where we're dependent on country systems, where we're dependent on their logistics, on their human resource, on their financial, their accounting systems. And we know that solutions exist to overcome issues. I was just Peter and I were just at a panel a moment ago, and I was talking about there's no justification for pilferage at the last mile when you pay healthcare workers, when something as simple as cell phone payments are available as a solution in every nook and corner. So that, of course, is a very basic example, but we're setting up a solution innovation scale-up fund to be able to scale up take simple solutions to scale, because those simple solutions exist. It's just that private providers don't have the capital to be able to invest to deploy them at scale. So I think it's very important that when you look at solutions, you also think about the wider scale deployment of those solutions, and not just experiment at a small pilot level to demonstrate impact and then write the paper in the Lancet. The actual proof is to be able to deploy it for human benefit at a large scale.
Thank you so much, Dr. Sania Nishtar, for your insight there. As you say, solutions exist, and it's a question of deploying them at scale. Thank you very much for joining us. I know you have to leave us in a few minutes, but hopefully you can stay for a few more minutes with us on stage. But feel free when you're ready to go to...
And I apologize in advance, because this week all of us are running from one event to the other.
Indeed,
it's a distinct honor to be here.
Thank you so much. Thank you for taking the time to be with us here today. I'd like to invite two more panelists to join us on stage. Dr. Petro Terre-Blanche, CEO of Afrigen. If you're around, please join us on stage. Thank you so much. And Peter Sands is also here. Please join us on stage. There's a seat in the middle. If you want to move this way, yeah.
I'll sit with Philip. I like to be with him.
Thank you so much to all of you. Let me come to you, Dr. Keeney, next from MPP. We often speak about equitable access as a goal, but from your experience, which collaborative approaches are already proving effective in expanding access?
Excellences, chers amis, avant de passer en anglais, je voudrais remercier la France et l'ambassadrice de nous permettre une fois encore de nous retrouver dans les marges de l'Assemblée mondiale de la santé pour une réunion qui nous permet de faire le point en manière d'innovation et d'accès dans les pays pour des technologies qui sont absolument essentielles. A clear lesson that we heard from many discussions around the topic of innovation and access, talking about one and the other, but it is clear now that innovation and access are not competing goals when partnerships are structured around public health needs. At the MPP, one lesson learned stands out. There is no single route to equitable access. Different health challenges require different forms of collaboration and different tools. Take HIV for an example. Through voluntary licensing and collaboration across the global health ecosystem, which includes, of course, the Global Fund, more than 20 million people in low and middle income countries are now receiving WHO-recommended dolutegravir-based regimen with TLD, the one pill a day fixed dose combination, being the most widely used. That is what access at scale looks like. But licensing alone is often not enough. Equitable access also depends on technology transfer, manufacturing capacity, regulatory strengthening, and long-term collaboration. This matters even more in pandemic preparedness. COVID-19 showed us very clearly that access cannot depend on a small number of manufacturing hubs concentrated in a few regions. Countries need stronger local and regional capacity to produce and deliver health technologies that when crisis hits. That is why initiatives such as the WHO MPP-led mRNA technology transfer program matter so much, and I look forward to having Petro talk about it. The 16 partners together help build manufacturing capacity, technical skills, and stronger regional ecosystems in low and middle income countries. What is encouraging today is that we are seeing growing recognition across the ecosystem, from industry to global health organizations and governments, that collaborative approaches can support both innovation and expand equitable access. If we want to be better prepared for the future, we need to keep building practical partnerships that connect innovation, manufacturing, and public health objectives so that life-saving products reach the people who need them most. And that is why access-oriented partnerships with industry matter so much. They are a key pathway to turn innovation into access. I'm especially pleased that this discussion is immediately followed by the intervention from Thomas Schickeneck, CEO of Roche, who will provide us with a very concrete example of our new partnership with Roche that we were proud to announce only a couple of hours ago. Ladies and gentlemen, as we are all worried by the new Ebola epidemic in Uganda and DRC, for which WHO Director General just declared a public health emergency of international concern, we are yet again called forward to translate our commitments into acts. For this particular Ebola strain, there is no vaccine, there is no specific treatment, and the risk of spread of the disease is high, as we were just reminded a few minutes ago. We know what vaccine and what treatment we need to develop and deploy in the affected regions. Let us come together in effective partnerships, show again that innovation and access together can make miracles. Thank you very much.
Thank you very much, Dr. Kinney, for your remarks. Thank you. And you lead us perfectly to Thomas Schinecker, CEO of Roche, to get the industry perspective and also acknowledge, as you said, Roche's recent voluntary licensing agreement with MPP. And perhaps we can find out more about what motivated that decision and how do you see these kinds of collaborative approaches becoming increasingly important for future outbreak responses, including emerging threats like hantavirus or the Ebola epidemic.
Yeah, thank you very much. As was just mentioned, today we signed the voluntary license agreement for Xofluza, the next generation influenza medicine. We know that influenza is a virus that kills up to 650,000 people every year, so a significant threat globally. And if you think about which are the viruses that can cause the next pandemic, clearly influenza is very much on top of that list. Clearly there are others as well, but influenza being a very important one. With that, we can provide access to 120 low and middle income countries. And why can we do that, or why? What we see behind that? We see behind that in a situation of a potential pandemic, but even outside the pandemic, it gives access to those that need most. Can you still hear me? Yeah, to those people that need it most. And let me just also say, this only works if rich countries are willing to pay for medicines. If we get to a world, this doesn't work, so maybe let this one works, okay? If we get to a world where rich countries then say, but I want the same price as Egypt, or I want the same price as Bulgaria, then what you have is less access. Because then what pharma companies will say, well, if we don't have any countries anymore where we can earn the money, we cannot reinvest the money in innovation, and then the future medicines will not come, right? So you can only do that and give medicines at a very, very low cost, or do these voluntary license agreements, if rich countries then show solidarity and are willing to pay. So for me, the key words around how you ensure access is solidarity. And, you know, and I heard a lot of things in the previous discussion. Some of the things I agree with, some of the things I don't agree with. For example, I can tell you, if I look back at COVID-19, and I was right in the middle of it, being the CEO of Roche Diagnostics, I didn't see a lot of solidarity from countries. It was not the manufacturers. It was countries saying, no, you have to serve our country first before you serve other countries. We tried to give equitable access. Now, what we were able to do, because we have, for the testing, we had 16 different components that came from a number of different countries. We could tell every country, yeah, you can do that, but just be aware then you cannot test anymore, because all the other components of the test come from every other country. So, you know, I think what countries need to do is show solidarity when it counts, not in a moment like it is today when we don't have a pandemic, hopefully, because, you know, in a moment where countries are under stress, they're getting pressure from their population, then suddenly I see a different picture. So that's the first thing that I would say. The second thing is, and Jeremy Farage said that at the previous event, he said that, and I fully agree with him, that a manufacturing site should not be a photo opportunity. It has to be practicable, it has to be sustainable. And I think this person from the EU Commission said it perfectly right. To have something, it has to run. It means it has to produce products constantly. If it doesn't run, if it's not maintained, it's basically like starting from fresh. So we have to think about that from a long term. And we have to think about the whole value chain from end to end, and make sure that raw materials, all the different components are actually available to scale up.
Right.
Because the reality is, if you have a manufacturing site in country X, but you have the raw materials in country Z doesn't supply to country X, then you have a manufacturing site, but it doesn't really matter, right? So we have to think that through, and we have to have really truly practical solutions, and not just, okay, let's have a manufacturing site so we can say we have one, because in the real life situation, I can tell you, it will not matter. Right. So we have to think about that a lot differently than what I'm still seeing today.
Yeah, thank you so much for that. And I don't know, Dr. Petro would like to talk about that in a minute, maintaining the manufacturing side, and I'll come to you and your experience in South Africa for that. But Mr. Duneton, if I can come to you next, and perhaps you can build on what we heard from Thomas there on, what do you think? He talked about the need for rich countries to be more, to have more solidarity, not just in times of pandemic. Can you build on that? And how do you think we bridge that gap in practice?
Yes, thank you. And d'abord, je voudrais dire merci la France, merci le Medicine Patent Pool, en français dans le texte, et merci Roche. Yesterday, we celebrated 20 years of UNITED, and a lot of you were there. And the point I was trying to make is the importance of access to innovation. In fact, the Minister of Brazil, the Health of Brazil, Padilla, said something very true that I heard today many times. Innovation without access creates injustice. And I think that what we see today is really to address that. This morning, I was with IPPS, and we launched with the NDI, with others, with MPP, by the way, the Coalition for Therapeutic for Pandemic, because there is a big shortage of innovation for the 9 families that have been listed as a priority and risk for pandemic. One of these is flu. So I said to Thomas just a moment ago that for me, my dream became true. And I want to commend and please a round of applause for Roche, because it's very important, and it's not, you are not the only one, the only company, but I know that it's a decision who comes from the top. And this is absolutely key. By the way, during pandemic situation with my friend here, Peter, we negotiate with Roche in particular to make available. It was not the perfect therapeutic, but it was important that you show the willingness to engage. So part of access is, of course, innovation. And we need to recognize that pharma company who invest in innovation has a key role. Of course, we need to create generic market. That was Marie-Paul was telling. And it's effective. It works. It works if we have, ecosystem. It is a bit mysterious, but I think that you can see what we are talking about with MPP, with Roche, with the Global Fund. Global Fund, we put, in a way, introduce 150 products over the 20 years. All of them have been picked up and scaled by the Global Fund, by the country. So this is an effective ecosystem. I want to add something about what we do in HIV. As mentioned by Anne-Claire, I was in Nairobi for the Africa Forward, and I had the pleasure to announce that we have an agreement with Gilead and South Africa to produce lenacapavir, the 2 shots a year for, in generic version, $40, produced in South Africa. This is something important. We had also announced agreement in principle with MSD for the new oral PrEP in a year, and we hope that the clinical data will confirm that. So, and I think that the shift was during the pandemic situation. We believe that regional production is part of the access, and in particular, regional production in Africa. So we have this all in common. I will stop there, but it's also why we are very proud to have funded Medicine Patent Pool. I think that what we see today is the best birthday present that I received for my 20 years in UNITED. Thank you.
Happy anniversary. Happy 20th anniversary. Thank you so much, Mr. Duneton, for your remarks. Dr. Petros from Afrigen, CEO of Afrigen, I now come to you and talk to us about your experience and your perspective at Afrigen. What practical capabilities and services emerging from the mRNA technology program, which Marie-Paul mentioned. What do you think those can help countries prepare and respond to future health crises?
Good evening.
Yes.
Good evening, and thank you for having me. Firstly, I proudly represent the 16 companies in the network for the mRNA Technology Transfer Program, and I want to do a shout out for those online and those present here. So 15 partners on 4 continents represented by manufacturing companies driving access and equitability, but also sustainability. We are a tangible product of a vision. And I've heard so much of a vision being translated here in the panel and the previous panel. But let me make a few points, and that will also translate in why this is sustainable and important for future. Firstly, access. Access through 3 parts. First, access to technology and knowledge. The mRNA Tech Transfer Program has not only developed technology and knowledge, they've transferred it. You cannot give anything that you don't have. And credit to the program and the partners, technology is being developed, demonstrated through a COVID-19 vaccine, validated and shared. 15 partners now have access to technology, at least at an R&D scale. Second importance of access is research, development, and innovation. Innovation is not a moment in time, it's a process. Innovation from research and development to a product in the market requires partnerships, it requires facilities, people, knowledge, regulatory systems, an ecosystem that will deliver on that. This program has fostered innovation through new product development, new products in development, improving mRNA technology for sustainability, for affordability, thermostability, and access. And lastly, access through local manufacturing, creating a network of supply chain, 134 different suppliers that will supply to an mRNA program from R&D right through to GMP manufacturing. Fostering partnerships and building capacity and capabilities on 4 continents, 15 companies, not only through mRNA technology, but regulatory and also GMP manufacturing capabilities. In a week from now, Afrigen will celebrate, and on behalf of the program, a GMP license. A first ever mRNA technology platform license from research and development, tech transfer internally to CMC and production. And the license will include a quality management system, which is drug substance, drug product, manufacturing, full finish, stockpiling capabilities, QC, QA, entire quality management system, regulated and licensed by an NRA that has ML3 capabilities. That capability prepare us for new product development, for preparedness, and not only for pandemic, but also for outbreaks, for epidemics, the ability to innovate, develop new products, and build the capacity that can respond, can train, can continue to build capacity and work hand in hand with our regulatory authorities to ensure we have true innovation from the concept right through to a product in the market that can not only prevent disease but also treat disease. Thank you for the opportunity, and I proudly represent this program and the 16 partners.
Congratulations, Dr. Petro, on that achievement. Congratulations. Thank you very much. I think it's important now that we get the community perspective, a sort of reality check as we discuss all these mechanisms to accelerate access. We'll hear from Agre Aluso from the Resilience Africa Network Action. We've discussed all these mechanisms to expand access, but from a community perspective, is there a disconnect between what is being discussed here and what people are experiencing on the ground?
Thank you so much, and it's a pleasure to be here to speak on this very important matter. I think all of us in this room, as those who are out there, communities that we work closely with, I've never had any contestation on the importance of equitable access, in terms of supporting access to important life-saving medicines in endemic or in pandemic and epidemic situations. I think that is something that we always unanimous around. And I think also the many brilliant examples that have been shown here from my very long-term friend, Petro, Professor, whom I've worked with for, from the beginning of COVID and seeing the transformation she's talked about. I think it's been one of the most exciting developments in Africa. And I've had a chance to come to her institution and also visit countries, and I'm, proud of that transformative impact. And of course, the leaders, global health leaders who have spoken, I think very brilliant examples of what needs to happen, and really just affirming that there is a very clear proof of case. There's no doubt that we need these kind of solutions at scale. But I think you asked the question of what the communities that I work with, and just maybe as a matter of reintroduction, because we are known for a very long time as Pandemic Action Network. We transitioned or rebranded ourselves. Part of the inspiration for our rebranding is actually to meet the moment, because many of us in this room have been concerned about the vicious cycle of panic and neglect. We wake up when things go wrong, and we think we need to meet the moment at the moment of opportunity, which is really represented in this room. And that's what our communities are asking for. Let's not wait for the things that are happening, like what's happening right now, for us to swing into action. We've been always reminded that we have more solutions than the problems. But I think the point of disconnect is the political choices we make, which is sometimes inspired by some, like what was said, and I'm happy you said it from the industry, that you are willing to do what was necessary, but countries were telling you, no, serve our people first. Those are the kind of challenges that communities are concerned about on both sides. Even community, because we work across the divide. Resilience Action Network International, which is our partner, connects the global constituency, and Resilience Action Network Africa, which I lead, connects the partners from Africa. And there's never any dispute that everybody on all sides, the communities, want equitable access. Because when Africa is burning, like now, Ebola is raging in Africa, nobody is safe. On either side of the divide, nobody is safe. So if we have equitable access to these countermeasures where the outbreaks are happening, like Dr. Mosoka said, if we have the countermeasures in DRC, in Africa, where we have most of these outbreaks, that can be accessed in real time, we would have less worry because we would be more confident than that this outbreaks, the episodes, could be contained, detected and contained quicker. But then I think what we really need to bring to scale is the political will, is putting things into frameworks that are accountable, that are predictable. I know there's quite a bit of what has been supported here, but I think opportunities that we have now post-COVID, and I don't think we can say post-COVID yet, where we are now negotiating for frameworks that can be anchored in accountability frameworks, like the pandemic agreement, like the PABS agreement, that can provide measures that are predictable and that can be relied upon to provide support in the interpandemic period to build the systems and build the resilience capacities. I think that's what we need to get to. That's what the communities are asking for, and we hope that the industry and particularly member states and citizens of the world can push the right button so that we do the right thing for our people. Yep.
For sharing the community perspective there, and thank you for highlighting the need to bring to scale political will as well. Peter Sands, Executive Director of the Global Fund, I'll come to you next. We've heard today a lot about the promising mechanisms and also the realities that countries continue to face. So in a context of constrained global health financing, how do we protect and sustain the progress that's been made while also strengthening preparedness for future pandemics?
Right. Well, to start with, I think we should recognize that much of the extraordinary progress in global health over the last 2 decades was achieved through providing equitable access to innovations. I mean, Mary-Paul, you mentioned antiretroviral treatment. Simply by providing antiretroviral treatment at scale, millions of lives were saved. Now, it took 8 years and millions died because it was too slow, but that has been a key part of why in the last 2 decades we've seen a faster increase in life expectancy for more people than has been experienced at any other period in human history. So while I am among the many who think we should change a lot about the way we do global health. We should also recognize that we're building on a record of extraordinary achievement. Now, we all know we got less money. It's all got a bit chaotic. So whatever basis we had before isn't going to work now. So what do? Well, we just have to get simply smarter. Everything we used to do, we have to do faster, smarter, more effectively than we did it before. And actually, we learned a lot from COVID, because COVID taught us that when it's people in rich countries who are threatened by a disease, surprisingly, a lot of the rules and the timeframes and things get broken or collapsed. So why can't we do that when it's people in poorer parts of the world? And that's exactly what I think we need to be doing, is we need to be saying, no, it shouldn't take X years from phase 3 to regulatory approval, or from regulatory approval to launch, or from launch to the generics. You know, we can collapse all those time frames. And actually, that's not just a pipe dream. What we did in partnership with UNITAID, with WHO, with Gilead, the innovator, and things, with lenacapavir, which has been mentioned, is go from regulatory approval in July to arrival in Africa in November. The first time we've had a major HIV innovation launched in Africa in the same year as it was launched in the rich countries in the world. We will have generics by first half of 27.
Let's say 2 months.
2 months. It keeps getting closer, and all credit to people like Philippe for the work that they've been doing on that. It's already in 9 countries in Africa, not just in pilots, at scale, and it'll be in 24 countries by the end of the year. We have never done a major HIV innovation at anything like that pace. And the thing is, though, we shouldn't think of this as the exception. We should say, that's the way it should be, right? That's how we should do this stuff. It takes an enormous amount of partnership. Lots of different agencies and countries were involved to make this happen, but people were motivated by the same vision. The other thing we need to recognize is getting it to the country is only the first step. And that's where ministries of health, communities, civil society play a huge role, particularly with a product like an HIV product, where often the people who need it most are not the highest up the political agenda, right? They're marginalized, they're discriminated against. So getting it to the people who benefit the most is a big deal. A couple of caveats. We can't do this for every innovation, right? There are loads of different innovations. And so we have to be pretty ruthless, and I come at this from the perspective of being a banker. We have to look really hard and say, which of these innovations are really going to change the curve? They're game changers in terms of epidemiology, in terms of saving lives. And just be ruthless on picking those and putting our efforts behind them. The second is, there's a constant temptation to search for the silver bullet. But basically, most medical interventions work best in conjunction with other ones. Lenacapavir, you test first. Some of the people you test, if you're targeting the right populations, some of the people you test will be HIV positive. You enroll on treatment. Some of them, an injectable product isn't the right answer. So locating each innovation within the broader armory of tools and ensuring that countries are in a position to optimize is essential, and we don't always do that as well as we could. There are plenty of examples where we've kind of got incredibly excited about an innovation and not really worked out how to make it fit best with all the other innovations. So I think this is doable. This is absolutely doable. And for all the flaws and fragmentation within the global health system, actually this is one thing where when we put our minds to it, we can do it quite well. And I think we owe it to the people who are threatened by these diseases, but frankly, we owe it to ourselves. And this is the point I want to make about pandemic preparedness. The better we are at providing accelerated access to innovations to fight the diseases in front of us and killing people today, the better we will be at doing it for diseases that turn up as new threats. We shouldn't make a false divide between what we do for pandemic preparedness and what we do to fight existing diseases.
Right. Thank you so much for that, Peter Sams. It's doable despite the constrained financing environment. Thank you for your remarks. And perhaps a final word from Marie-Paul.
Well, I think it's really exciting to see again that you are here, so many, to hear about the progress that we are collectively trying to make in this global health with all the threats and the challenges, with lack of funding. But we need to keep the fire moving forward for innovation, for access, for the people that we try to serve. And for this, thank you to all the countries helping us, with France inviting us. And not only for that, France was a major funder, the first funder for the mRNA technology transfer program in South Africa. Thanks also for the Global Fund. Thanks to Gavi. Thanks for United, who's the main funder of the MPP. And thank you for bringing this talk together tonight.
Thank you for your outstanding contributions. Please, a round of applause for our panelists. Thank you for joining us. You may return to your seats. Thank you all. We've heard throughout these discussions, the two dialogues, that the challenge is no longer a lack of knowledge about what works. The challenge is implementation, coordination, and political will. The question now is whether we align all the tools that we've heard about and align them quickly and sustainably enough to meet this moment. We are now nearing the end of our discussion. It is my great pleasure now to invite Deus Mubangizi, Director of Medicines and Health Products Policies at WHO, to deliver closing remarks.
Thank you so much. What an evening. I think I was profusely writing notes as people were speaking. And I would like to start with what Peter Sams ended up with. We will be better prepared for tomorrow's pandemic if we are prepared now. And the best way to prepare for a pandemic is to have resilient health systems now, because then they will be able to detect these pandemics early and respond effectively. So let's do it now, not wait for tomorrow. So I thought I should get off script and slot that in. But then let me first of all then go back to the script and thank, of course, excellencies and distinguished ministers and colleagues and partners here. First of all, let me bring you greetings from my Assistant Director General, Dr. Yukiko Nakatani, who should have been here with us, but of course, because of many priorities, competing priorities, she was not able to be here, and I hope I will measure to her into her shoes. But having said that, she is Assistant Director General of Health Systems. And for me, that again, the point that I was making, looking at health systems, not only looking at health products, not looking at, looking at health systems. We can make all these products, even if, Roche, thank you for that license. If the health systems cannot deliver them, and the health cannot deliver them into the arms of or the mouth of the patients, then we will not have achieved access. And what we have heard today, and I'm getting off script, is that we should not think of access at the end of the, we should start thinking of access at the very beginning. Once we are talking about that innovation, how shall we deliver that innovation to the people? We start thinking about, otherwise it will be too late when we think about access later on. So let me make this opportunity to thank France and our long-standing partner MPP for co-hosting and organizing this very important event. I also want to congratulate all involved in the early announcement we had regarding the license agreement to expand access to influenza treatment in low and middle income countries. This agreement is an important step towards improving equitable access to influenza, antivirals, and strengthening a global pandemic preparedness. WHO welcomes this collaboration and its contribution to protecting at-risk populations worldwide. We have heard today a strong and consistent message from member states and partners. Progress is possible when we work together. I think the last panel emphasized that. When we work together, there's nothing that is impossible for us, but we must work together. So aligning remains a critical gap, and often we've had, sometimes we talk about it when we are under stress. We say, my people first. And we forget that the Ebola will move from DRC or my country, Uganda, and find you wherever you are. So let's align and prevent these epidemics and pandemics. We must also be clear-eyed about the context in which we are operating. While the acute phase of COVID has passed, the acute phase, I'm not saying that COVID is gone, the acute phase is past, countries are facing multiple and competing priorities, many beyond the health sector, placing increasing pressure on political attention and financing. At the same time, if we look back over the last 12 months, we see persistent pattern of regional infectious disease outbreaks, which serve as a reminder that the question is not if another pandemic will come, but when. In fact, we're not talking about when, because it has happened. Hantavirus, now we're talking about an Ebola outbreak. So this should remind us that really we should not relax. And there is nothing, I liked what my friend from African CDC talked about. There's no peace times, and in Africa, every day is a crisis time. When I look at our colleagues in emergencies, the number of signals they receive every day, every month, in thousands. And any of this could easily trigger into a pandemic or an outbreak. So we should remind ourselves it's not when, we should always, every day, try to be prepared, and collaboration is the answer. We require sustained investment in resilient health systems, capable not only of responding to crises, but of delivering quality, affordable health products to people every day. It's those supply chains that we set up that are able to operate now that will help you deliver those items when crisis hits. Some of the things cannot be just scaled up. We have had even manufacturing from our colleague from Roche, manufacture even from Afrigen. Manufacturing must be kept warm. If you, because the pandemic has stopped and you lay off all the workers, or even you switch off the air handling systems, by the time you actually switch them on, the pandemic would have killed thousands. So there must be, these systems must be kept warm, and it's an investment. I know Peterson talked about from a banking, but also an investment in keeping some of these systems warm is important in contributing to our resilience. So we require sustained investment in a resilient health system capable not only of responding to crisis, but also delivering quality, affordable, and products to people every day. Given the dynamics, maintaining momentum we have built and deepening our collective resolve is not an option. It is an essential. The Afrigen we have had from Petro is an essential. It's not something that, it's not a luxury. We should be proud. I'm a proud African here to sit with Petro and say we can have mRNA technology from R&D to lab scale to GMP scale. So that is something that we should be proud of. And that is the resilience that we are talking about, that will be deployed when we are talking about a new outbreak. So the momentum and the successful generation of new health products starts with innovation, but it does not end there. Innovation must be connected to the full value chain, from research and development to licensing, manufacturing, financing, procurement, and delivery. We must expand sustainable funding for research and development, strengthening translational capacity to move products from the bench into the clinic and on the bedside, and design new financial models built on shared responsibility, mutual commitment, and equitable benefit. Approval is not the final, the finishing line. Access is. Our success will be measured by whether health products reach those who need them most when they need them. These responsibilities are shared. Governments, industry, and global health partners must work together, not in a parallel, but in genuine partnership. What will determine whether we succeed? Of course, we need predictable financing to fuel the progress we seek in alignment with agreed priorities. Effective collaboration and coordination maximizes the return to on these investments. Alongside sustained political commitment, we know this is a marathon more than a sprint. Ultimately, and this is in closing, this is about aligning the global health architecture, ensuring that each part of the system works together rather than in isolation. This delivers better products for people everywhere and a world better prepared to respond to health challenges that lies ahead.
Thank you so much. Thank you, Mr. Mubangizi, for those powerful words. Thank you so much. That was a great way to close our session. Thank you so much. We must all work together. And that is the end of our broadcast moment. Thank you to all of you joining us online. Thank you for your engagement and your commitment.